Well, good afternoon, and thank you for joining us this afternoon for the webinar Wednesday with Dr. Cox. This is Julie Cox-Sid. We like to be punctual, so we're starting at 12:30, and want you to know, like everyone usually asks, where are the notes? So check the notes. They're in your handouts panel on your attendee panel, and then there's a questions panel also there. Yes, I know, he's pointing out that I have the disc on there. And and put all of your questions in the question panel. We'll bring those up either at the end or throughout if they come up and they're appropriate. This afternoon, we should be relatively short, focusing on the cervical spine. Dr. Cox is also going to demonstrate technique on the Cox table by Haven, that is the force table. So midway through, before he starts showing treatment, I will bring that table in so you can watch him as he applies forces. So again, this afternoon, if you want to see the video larger or the slides larger, you can move your line between the two up or down to make one bigger or smaller. And otherwise, I'm going to turn it over to Dr. Cox.
Thank you for studying with me today. We will be discussing a very serious form of care, treatment of cervical disc herniation. Huge difference between treating cervical and lumbar disc herniations. In a low back, all we have are a few sacral nerve roots sitting at L4 and 5. In a cervical spine, we got a 7-8 millimeter spinal cord to contend with. Therefore, at the outset, this is an algorithm of treatment protocol that you can run off. I'm not going to go through this. I'm going to show you. But you can, if you want, you can copy that for your use. I always like to begin with a study done at Palmer on low velocity variable amplitude spinal manipulation, Cox technique. They were studying treating the big white Worcester rat with Cox technique. And it was published in Evidence-Based Complementary Alternative Medicine in 2015. And this was the paper. They even commented on treating neuropathic pain. That is the burning type of extremity pain due to the chemical inflammatory changes within the dorsal root ganglion via interleukins 1B, interleukin 6, tumor necrosis factor alpha, the T1 cytokines, as opposed to the T2 cytokines, which are what? Anti-inflammatory. So you'll note that they were treating and said neuropathic pain in this paper that you can retrieve. The pain radiates into the legs is a common component of low back pain. But I wanted you to know that I'm treating cervical spine, and you must know that cervical myelopathic changes with edema will cause low back pain without any change in the upper extremity. We get into things like subacute combined degeneration of the spinal cord. We talk about funicular compression, far lateral, sparing the upper extremity, only causing lower extremity pain neuropathically. And when you read Donifer et al., note that neuropathic pain significantly increases its debilitating burden. And they state here that 1 month of flexion distraction, they called it Cox technique, produced greater analgesia in these back pain patients who had leg pain compared to those without leg pain. So what they were doing in this study, and we did it the same thing with the cervical spine that you've read in the research, we used a Cox instrument made at the University of Iowa, 1/12 the size of the one that we're using today on human treatment. And so this is 1/12 the size, treating the Worcester rat, and they're using low amplitude, low velocity variable amplitude distractive force. This paper by Chow, as we move to the treatment, I just urge you to remember about the mechanical effects of distraction on any segment of the cervical spine. Shows that the horizontal distraction force that we are applying increases the disc height. So that when you and I are treating, and we look at the work of Jun that just came out a year ago in chiropractic manual therapy about the potential mechanisms of relieving spinal stiffness, that is increasing physiological range of motion. that there are 7 themes that outline what must happen in the spine for a successful clinical outcome. Number 1, there are changes in muscle activity. That is, muscles like the multifidus will show greater strength, increase in mobility, greater range of motion, decreased pain, increase in the pain threshold, change in muscle tissue behavior, and afferentation. That is a treatment of the lateral spinal thalamic tract response, the posterior tracts of gall and burdock, as they convey messages from the substantia gelatinosa to the somatosensory cortex of the brain, and the pyramidal interpretation resulting in corticospinal response with the carrying of endorphins and dopamine for pain relief. Put another way, consider the research work that we did on a federally funded study covering what are the changes in a vertebral segment when you apply Cox flexion distraction technique. This was done at Loyola Medical Center, Heinz VA Hospital, University of Illinois, National and Palmer Universities of Chiropractic. It was a collaborative, federally funded study. And we found 5 changes took place when we used the technique that you and I are about to share. Number 1, we increased the disc space. 2, we dropped intradiscal pressures. Now, if you remember, and I'm not going to go into it today, but I will summarize the study, published a published study on cervical spine intradiscal pressures. And as opposed to a lumbar disc, which dropped up to 192 millimeters of mercury, a cervical disc at C5, C6, applying this technique in an uninvolved, non-rigored cadaver, dropped intradiscal pressures up to as high as 500 millimeters of mercury. Second, we increase foraminal area. We restore or maximize physiological range of motion, which then results in positive afferentation. At this point, I'd like to mention to you that on April 17 and 18 in Fort Wayne, we will hold a thoracic spine conference. And at that conference, we will be covering a 2-hour lecture on afferentation. That is, we will cover these physiological biomechanical changes within a spinal segment, but we will also be discussing the chemical inflammatory changes within a dorsal root ganglion, a nerve root, a substantia gelatinosa of Rolando, which is probably at least half or maybe more of the change that you and I see when we benefit patients with spinal stenosis. Keep in mind, we will present the work from CMCC and others that show the reduction of the chemical inflammatory agents when we deliver spine manipulation. I think you will enjoy that. The other spine changes that must take place when we do the technique that you're about to see are the number 1, we must increase physiological range of motion. That is, decrease spine stiffness. Number 2, as shown by Wong and Kochuk, we must strengthen muscles. Number 3, as Beati showed in 4 papers, and I will present all 4 of those papers in Fort Wayne for your erudite study, Beati showed that there must be an increase in fluid imbibition through the Wallace buds within the end plate of a vertebra, from the cancellous vertebral bone through the end plate into the nucleus pulposus of the disc. This has been shown by diffusion weighted imaging, showing the apparent diffusion coefficients, the anistrophy changes of flow of fluids that take place when we deliver this spine manipulation. Then we'll blend that with the work of Kuo. Kuo showed that distraction enhances the nutrient supply into the disc and promotes what? In his words, the disc cell proliferation of degenerated, degraded discs. For me, this represents one of the very exciting things about the work that you and I do, in which we're about to study together. When you think that we are putting in chondroitin sulfate in the form of pernicanalicculus, the highest source of glycosaminoglycan known today. So as Kuo says, distraction treatment stimulates circulation, as does Beate, Wong, Kochuk. As we treat, think about the nutrient supply to lower chemical inflammation, enhance chondrocyte activity. And then finally, the work of Chung from Radiology Journal. And Chung showed that when you and I do this technique, we are increasing disc space height, we change the disc shape, and we reduce the intervertebral disc pressures. We separate by widening the disc space, relieve compression of adjacent nerve roots, and we widen facet joints. So before we ever place a joint into physiological range of motion with what we call protocol 2, we always distract the spine. Keep in mind, in osteopathy, we are taught the key is that we stretch tissues. As we stretch tissues, we break adhesions, we create physiological range of motion, we stimulate circulation to carry away the biodegradation products of nuclear disc degeneration, we drop pressure on nerve roots, and we increase intervertebral disc space height. Those are the things to think about when we are applying distraction to the cervical spine. So we look here, and we see a C4-5 disc herniation. There's no way any of us practice very long, like tomorrow or yet today, without seeing this. A left-sided intervertebral disc protrusion with leaking nuclear material into the osteoligamentous canal. Incidentally, you remember we used to call that the intervertebral foramen? It's not a foramen, it's a canal. It's very long. And when nuclear disc leaks into it, it compresses dorsal root ganglion and exiting nerve root, as you see here. So here we have an L4-5 left far lateral disc prolapse. We have small C5, 6, and C6, 7 discs, 4, 5, 5, 6, 6, 7. Now, when we treat, we always contact the arch of the vertebra above the disc herniation. We never contact the arch of a vertebra below such a disc herniation, because if we do contact here, we would be driving nerve root into that disc and aggravate the patient. We always, in using manual distraction or automated distraction, we always contact the triple joint complex above, in this case, C4-5. But in doing that, we will be reducing 5, 6, and 6, 7, because we're above, we're applying a distraction force. If we were to contact, say, down here at C7, now we could be driving nerve root into the level here and here. So always contact above the disc level of herniation, as long as you're doing it manually. If we do the occipital restraint, which I will describe shortly in clinical round, then we will contact below the disc herniation, in this case at C7, as we distract cephalad with a downward caudad force at the T1 segment. We'll go over that again in clinical round. Here would be another example. In fact, this is the same patient. We said we had this large C4-5 far lateral disc herniation. Well, look here at C5, C6. On the opposite side, we also have leaking nuclear material into the osteoligamentous canal. At C6, 7, we have what? A more paracentral disc herniation with a high intensity zone, which is incidentally what? Inflammatory fluid. So we have 3 discs in one patient. Woe be myself as a clinician, were I to contact C6, 7, drive nerves into these 2 disc herniations. So we're always going to contact above I'm treating what? 3 disc herniations in one patient. Are we together? Okay. So we're going to go to the instrument. I'm going to share with you 2 techniques of treating disc herniation. This is all protocol 1. It is not going to involve protocol 2 because our lesson today is the treatment of cervical disc herniations. Can I ask you a question? Do you think that treating upper extremity pain is quite challenging? I always did. I can remember using, and this is a personal thing, I would use cervical brake techniques. Once in a while, the patient said, boy, doc, that was great. Sometimes they said, doctor, that really aggravated me. So practicing the first rule of Hippocrates, don't harm the patient. Therefore, you might want to consider that what we're going to share might help your patients, as it has mine and hundreds of other certified Cox practitioners. When you saw the cervical research that we did at Loyola, we did studies on cervical brakes. Did you notice sometimes the intradiscal pressures went up very high with cervical brakes? None of them went up with our work. So you decide which is best, to drop intradiscal pressure to create a centripetal force or increase the intradiscal pressure with the potential of aggravating the disc. Therefore, we will go to the instrument. We will treat 3 levels of disc, which is not uncommon for you and I to see as clinicians. We'll go to the instrument now.
Okay. By the time that you and I see a patient like this with 3 disc protrusions and prolapses, you can rest assured that the sympathetic nervous system is in overdrive. That the DRG is now innervating that disc more than before with grave communicantes. That this patient will have a great degree of tightness, reduced range of motion, pain, disability in the upper thoracic spine called the upper thoracic syndrome. So when we treat, my point is, I will use trigger point treatment with a T before I treat disc herniations. I want to relax these upper thoracics, which are sympathetic innervation, controlling respiration, heart rate. We live in a sympathetic atonic society where we have a lot of stress. So people appreciate this type of relaxation. So I treat those trigger points. Then when we treat the intervertebral disc hernia, I release the long Y-axis distraction of the Thomas headpiece. I place the spinous process in the web of my thumb and index. In this case, what level? C4, because we have C4-5, C5-6, C6, C7 disc herniations. So I'm going to begin with foramen magnum pump as a tolerance test. So I place the base occiput in my hand. I very slowly extend distraction, asking my patient, does this cause you any discomfort anywhere in your spine, your arms, or your legs? Why do we start with foramen magnum pump? Because as you can watch the chart, I'm applying 2 pounds of distraction force to this spine, okay? And when I do that, I am stretching the dural sleeves of the entire spine. If you want to find the level of somatic dysfunction, disc herniation, inflammatory exudate, just do foramen magnum pump. I use it as a diagnostic and a tolerance test both. As I apply this, and my hand is lifting cephalad, as I apply the same force with the tiller bar, I ask, do you feel any pain anywhere in your spine? Because even as we discuss lumbar disc stenosis, you will find patients say, Doc, I feel the discomfort here, even into my buttock or lower extremity when you stretch my neck. They think that's odd. You and I don't. because we understand the spinal cord hangs as a sac within the vertebral canal attached to the pia and the dentate ligament in the neck. As we tolerance test for our 3-level, 4, 5, and 6 disc herniation, this contact and this, if you watch the force table, I'm using 1 to 2 pounds. You see that very slight elevation of the static blue line? That's 2 pounds. If there's no pain at foramen magnum pump, I move down to C1, C2, C3, 4, and I'm going to stop at C4 because I have herniations at 4, 5, and 6. I don't want to move below it and take a chance of compressing a nerve by driving that nerve into the disc lesion. So if I tolerance test, and most of the time you have no problem. Some people may feel a little tingling in the hands or arm. That's okay. Carefully monitor. But as I treat these 3 levels of disc, this is going to be on the C4 arch. I close down like a monkey grip via V and observe as I lift to decrease lumbar lordosis, flatten the curve, so that as I apply, and watch the force I use, I'm applying here about 2 pounds of force. That's where I suggest it. I always start this gentle. You will find that many people say, "Doctor, that's what gives me relief." If that gives relief, I'm not going to go any higher until I show close to 50% relief of radicular component or centralization of the pain above the elbow. So I apply 3 20-second distraction forces called protocol 1. Each of those 3 20-second distractions looks like this. You okay, Rick?
Yeah.
I make this contact. Now watch me move to the taut point. I contact C4, taut point, 1 to 2 pounds of distraction force. And you see the blue line just barely moving from flat. This will give you tremendous relief. As a patient says that their arm pain centralizes, I'm going to increase it to 4 pounds in via V. I go from 0 to 4. You can see the increase in the sine wave, am I right? Can you see it? I can measure the force. Doctor, if 2 pounds helps them, I put it in my notes. I applied 2 pounds at the C4 level today. Tomorrow, if they're improving and I increase it to 4 pounds, I put that into my chart. I have a documentation of objective relief along with the subjective relief of the patient. Okay? So this would be the manual application of disc herniation in the neck. Always contact above the disc, apply the 3 20-second distractions consisting of tautness and the 5 4-second pumps, reducing cervical lordosis, my contact and the tiller bar moving in parallel, and you can see the force I'm using is about 3 to 4 pounds. That's the maximum I use. Now, there is another technique which some physicians prefer over the hand, and it is with the occipital restraint. So I can bring the occipital restraint over, attach it underneath by Velcro to the headpiece, bring this one over, and wherever they cross will be the fulcrum from which I am applying distraction force. When I'm using the cervical headpiece, I contact below the last disc. In this case, if it's C4, 5, 5, 6, 6, 7, I'm going to come down to T1, make my contact, watch the force screen, I move to the taut point, and I apply my 2 pounds of force. You okay, Rick? That's 2 pounds. So I'm applying a caudad contact to the 3 discs as I apply my 5 4-second pumps, and repeat 3 20-second distractions. Now, I must make a point to you. If you're dealing with C7T1 involvement, that's where, if you contact with any PA pressure, you increase C7T1 pressure. That was a study done at Loyola Hines VA Hospital, to great surprise to all of us in the room. In fact, one doctor, one of the scientists at Loyola said, you know, there must be something wrong with the equipment. C7T1's increasing. Well, there were some verbs. The guy said, there's nothing wrong with my equipment. It's what you're doing. Well, it turned out this way. C7T1, the question was, is C7 a cervical vertebra or is it the first thoracic vertebra? Because it really behaves like a thoracic segment. The moral of that story, clinically applied, is this. If you have C7T1 herniation, always come down to around T5. Apply taut point, and you can see my force. Now down here I'm applying a little more force. I'm actually going from a -5 to +4. So I'm applying about 8 pounds, but I'm going through several segments in order to increase the C7T1 space. So I threw that in as something. If you have C8 nerve root involvement, you have pain down the inside of the arm, a C8 nerve. Always don't use a PA force of C7T1. Contact above, lift, and reduce cervical lordosis. So the treatment, 2 forms of care for disc herniation with the occipital restraint and with the hand contact only. So I feel that I have covered adequately what I set out to do, the treatment of cervical discs. There's no way you and I escape seeing them. To me, they're more difficult than a low back because in the neck you got a spinal cord about 7-8 millimeters sitting at C5-6. Down here all I got is a few scrawny sacral nerve roots that have left the cauda equina. So I'm ready for the questions now. If you think there's any value in this, I wrote this book. It's called Neck, Shoulder, Arm Pain. This is the 4th edition. You can get it if you think that there's any value in this approach to treating serious neck pain. And also remember that this is the neck, upper back, and shoulder pain and arm pain book. This explains all the dermatomes in the spine. It explains what disc herniation does, how we treat it, the 50% rule, how we treat degenerative disc disease, spinal stenosis, degenerative disc disease, subluxations, rib subluxation, disc herniation, scoliosis, and compression fracture, and describes the treatment. So the patient can read this, understand their condition, and how we are treating it. Are there any questions?
There aren't yet, but if they have any, they can send them in.
Send
So I'm
them
just
in.
going to do this.
Okay.
Our next webinars in May are going to be thoracic, coming right off of our thoracic spine course in April. So we'll do the thoracic disc May 5, thoracic spine spondylosis May 19. If you have more interest in cervical spine, we have a series of 8 cervical spine courses online for CE. Just go to the coxtechnique.digitalchalk.com. That's our learning management system. Certainly check out the textbook, a great resource. We do have live workshops, small groups, 2 to 4 doctors at a time with a certified doctor in their office. Online CE, a lot to choose from there, 160 some hours. And then the Cox seminars, our next one will be lumbar spine, the end of this month, April 29 to May 2. We'll do our new course this fall on extremity sport and rehab, and we'll have cervical spine this summer. Cox 8 force table, if you're interested, talk to Amanda at Haven Innovation. She'll be happy to chat with you about that. And then all of the ways to get in touch with us. I maintain all of those. If you have any questions, certainly ask me. Main source is coxtechnique.com. I will load this to the YouTube channel so you can look at it beyond this course. And we appreciate your time this afternoon, and know that you'll be seeing a cervical herniation disc this afternoon, no doubt. So have a good day. Thank you.